Mahindra presents Family Premier League Season 2. Choose your theme, picture or share or family.
Good evening. Good evening, everyone. Am I audible? Am I visible and audible? Hi, Vivek. So, I'm Dr. Shanmugapriya, Professor and Head of the Department of Biochemistry at Government Thoothukudi Medical College, and I'm your Unacademy educator for Biochemistry. And today's session is on must-know case-based MCQs, and I have planned to discuss few cases based on carbohydrate metabolism inborn errors. Because recently we discussed FMGE revision series, quick revision series on carbohydrate metabolism just got over in the Unacademy app. So I thought if we have all cases related to carbohydrate metabolism, that will help you in recollecting all the facts. Yeah, that will help you apply the knowledge which you have gained also. So that's the plan for today's session. And before we begin the session, let me tell you a few facts about Unacademy plans. Plus subscription gives you an access to both live and recorded sessions. It also gives you an access to a question bank with 25,000 plus questions. And most of these questions are clinical case based, and all these questions are framed based on the latest pattern. And for every question, a detailed explanation is also provided. An iconic subscription gives you an access to not only Unacademy platform, it also gives you an access to PrepLadder platform. And special class features include interactive live sessions. You will be able to participate in polls, and using the raise a hand option you will be able to interact with the educator one-on-one, and you can get your doubts clarified real time. And this is the limited time offer that is being provided for Unacademy subscriptions. If you buy 24-month subscription, you get 4 month subscription free, and if you buy 12-month subscription, you get 2 month subscription free. And additionally, if you use my code BIOCHEMLIVE, my code is BIOCHEMLIVE. If you use that code, you get an additional 10% off. So if you plan on subscribing to Unacademy, I would say this is the right time. And this is about the free grant test that is being conducted for FMG aspirants, which is on 31st October Sunday between 10 a.m. and 1 p.m. You will have to attempt 300 MCQs. And I am always in favor of grant tests. This is the best way of knowing where you stand, and this will help you in working further. So this will help you understand your weaknesses so that you can start working on it. Yeah, so I suggest that all FMG aspirants take this up. And these are our toppers in the latest NEET PG September 2021 exam. The highest mark was 694 out of 800, which is very impressive. And we also have structured batches for all upcoming exams. Currently, we have Target NEET PG 2022 batch. This batch covers all 19 subjects in depth. And we also have clinical case discussions and instruments batch. So that's about Unacademy plans. Let's start discussing MCQs. So the first question is, a neonate presents with hypoglycemia which does not respond to counter-regulatory hormone administration. So the clue that is given to you, there are two clues that are provided to you here. 1 second. So you are provided with two clues here. The first clue is hypoglycemia. The other clue is the hypoglycemia does not respond to counter-regulatory hormone administration. So the probable causes, can any one of you try answering this? If it's hypoglycemia, based on that, is there any choice which you can exclude here? Vivek, can you try answering? Or anyone else who's in the live chat? Narendra Singh, very good. Narendra Singh says it is choice C or von Gierke's disease. Good. Any other options? Good, Narendra Singh. Shrishti also thinks it's C. Good. So just by the term hypoglycemia, I would exclude choice A, which is McArdle's. Yeah, because McArdle's is muscle phosphorylase defect. And whenever there is a defect of muscle glycogen phosphorylase, it is muscle glycogen phosphorylase defect. And whenever there is muscle phosphorylase defect, has got nothing to do with maintaining plasma glucose. So it does not present with hypoglycemia. Yeah, muscle glycogen phosphorylase defect would only present as exercise intolerance. So just based on this fact of hypoglycemia, I would exclude choice A. And then to exclude choice B and D, I'll give you few clues. Yeah. So I'll first tell you few facts which you should all recollect about glycogen metabolism and glycolysis. Based on which you will be able to have a mind flow chart to make a diagnosis of glycogen storage disorders. Okay. So the first fact which I want you all to recollect is there are only two pathways in your body using which we try to maintain plasma glucose. So those two pathways are, number one, liver glycogenolysis, the other one is gluconeogenesis. So what are the two pathways which can maintain blood glucose? One is liver glycogenolysis, the other one is gluconeogenesis. And for both these pathways, there is one common apex enzyme. What is that common apex enzyme? It is glucose-6-phosphatase. So this tells you whenever there is a defect of glucose-6-phosphatase, neither glycogenolysis nor gluconeogenesis can maintain blood glucose. So it is going to definitely present as hypoglycemia. Yeah, and that hypoglycemia will be severe and it will not respond to counter-regulatory hormone administration, because any counter-regulatory hormone which you administer, yeah, it can be something which is as strong as glucagon, or it can be something which is as weak as cortisol, that is immaterial. All these counter-regulatory hormones try to increase blood glucose only by stimulating glycogenolysis and gluconeogenesis. And if it's a glucose-6-phosphatase defect, both these pathways come and stop at that point. Beyond that, it cannot increase blood glucose. So if the question classically states that a neonate presents with severe hypoglycemia which does not respond to counter-regulatory hormone administration, that is a key that is given to you that the condition is caused by a defect of glucose-6-phosphatase. And the defect of glucose-6-phosphatase is called as von Gierke's disease. It is called as von Gierke's disease. So there are so many defects which can cause neonatal hypoglycemia, but the only disorder which presents as neonatal hypoglycemia which does not respond to counter-regulatory hormone administration is von Gierke's disease. Yeah. Now the third fact which I want you all to know is only liver glycogenolysis can increase blood glucose, but muscle glycogenolysis cannot. Yeah, have we discussed this before? I've always told you liver glycogenolysis can increase blood glucose, but muscle glycogenolysis cannot. If you want to know why, reason is muscle does not have glucose-6-phosphatase. It is because muscle lacks glucose-6-phosphatase. So what is the purpose of glycogen that is stored in muscle? The muscle glycogen is used only for muscle purposes. It is used only for muscle as a fuel during exercise. So muscle glycogenolysis helps only in providing glucose as a fuel during exercise. So why should we know these statements? Only when you know these statements, you will understand that whenever there is liver glycogenolysis defect, it is going to present as hypoglycemia. Good, Aditya Karthikeyan. So whenever there is liver glycogenolysis defect, it will present as hypoglycemia. Whereas if it's muscle glycogenolysis defect, it does not present as hypoglycemia. Instead, it presents as exercise intolerance. Muscle glycogenolysis defect will present as what? It presents as exercise intolerance. Intolerance particularly to anaerobic exercises. Why not aerobic exercises? If a person performs aerobic exercise, the person is going to utilize only fatty acid. And in this person, there is no defect of fatty acid oxidation. So that will happen normally. So only when you ask a person to perform an anaerobic exercise, the person will complain of painful muscle cramp. Yeah, that is what we mean by exercise intolerance. Intolerance particularly to anaerobic exercise is the presenting feature if a person presents with muscle glycogenolysis defect. Okay, so this is about gluconeogenesis defect and glycogenolysis defect. Now what if there is a glycolytic enzyme defect? I want you to know that glycolysis is indispensable. Yeah, glycolysis is indispensable for RBCs and white muscle fibers. Yeah, RBCs and white muscle fibers. So if there is a glycolytic enzyme defect, yeah, if there is a glycolytic enzyme defect, what are the cells which get affected, all of you? Very good, Dinesh. What are the cells which are affected? RBCs get affected and muscle gets affected. When RBCs get affected, RBCs won't be able to generate ATP. So that presents as hemolytic anemia. Please understand this. Glycolytic enzyme defects always present as hemolytic anemia. Whereas when muscle gets affected because of glycolytic enzyme defect, that will also present as exercise intolerance. Yes, Dinesh. Phosphofructokinase 1 defect is one example. So that will present as exercise intolerance, against intolerance to anaerobic exercises. Do you all understand this? So liver glycogenolysis defects will present as hypoglycemia. Muscle glycogenolysis defect will present as exercise intolerance, intolerance particularly to anaerobic exercises. Glycolytic enzyme defects will present as defect of RBC and defect of muscle. Defect of RBC will cause hemolytic anemia. Defect of muscle will cause exercise intolerance, and additionally CKMM level will be elevated. Are you clear about all these facts? Yeah, if you're clear of all these facts, then you will be able to understand every glycogen storage disorder without a doubt. Okay, so now I'm going to tell you about all glycogen storage disorders, particularly the 7 types. Yeah, 7 types of glycogen storage disorders. So first about type 1 glycogen storage disorder, I will tell you for every disorder the name, and then I'll tell you the enzyme defect. Yeah, first let's try to understand that list, and then you will tell me what are the defects that are observed. Okay, so type 1 glycogen storage disorder is otherwise called as von Gierke's disease, and the enzyme which is defective is glucose 6-phosphatase. This we all know, right? Type 1 is von Gierke's disease. It is caused by a defect of glucose 6-phosphatase. Type 2 is called as Pompey's disease. Type 2 is called as Pompey's disease. It is caused by a defect of alpha glucosidase. And alpha glucosidase is a lysosomal enzyme. Yeah, it is a lysosomal enzyme. So if the question is which is the glycogen storage disorder, which is also a lysosomal storage disorder, please choose type 2 or Pompey's disease. Do you all understand this? If they ask you which is the glycogen storage disorder, which is also a lysosomal storage disorder, your answer should be type 2 or Pompey's, which is caused by a defect of alpha glucosidase. Now type 3 is called as Cory's disease. Yeah, we have a mnemonic for this, right? CD. Cory's disease is caused by a defect of debranching enzyme. So type 3, Dinesh, you're right. It presents as cardiomyopathy. Type 2 presents as cardiomyopathy is what Dinesh is saying. So type 3 is called as Cory's disease. How will you remember the enzyme defect in Cory's disease? Have a mnemonic CD. It is caused by a defect of debranching enzyme. Type 4 is called as Anderson's disease. AB. Anderson's disease is caused by a defect of branching enzyme. Okay, type 4 is Anderson's disease, A followed by B. It is caused by a defect of branching enzyme. Type 5 is McArdle's. Yeah, type 5 is McArdle's, M for M. It is caused by a defect of muscle phosphorylase. Okay, type 5 is McArdle's, M for M. It is caused by a defect of muscle phosphorylase. Type 6 is Hurst disease. 6 is Hurst disease. It is caused by a defect of liver phosphorylase. Hurst disease is caused by a defect of liver phosphorylase. Type 7 is Tarrow's disease. It is caused by a defect of phosphofructokinase 1. Yeah, type 7 is Tarrow's disease. Yes, Bilal. So type 7 is Tarrow's disease caused by a defect of phosphofructokinase 1, and we all know phosphofructokinase 1 is the rate limiting enzyme of glycolysis. So are we clear about this sequence? Type 1 till type 7, we know the name, we know the enzyme defect. Okay. Now can you all check type 1? Yeah, just check the disorder which I am telling you alone. Check type 1. type 3 and type 6. Yeah, type 1, type 3, type 6 one by one. So type 1 is glucose 6 phosphatase defect. What did I tell you about glucose 6 phosphatase? I said it's an enzyme which is common to both glycogenolysis and gluconeogenesis. So when that common enzyme is defective, what will it present us? Yeah, what will it present us? It will present us hypoglycemia. Check type 3. Yes, type 3 is Hurst disease caused by a defect of debranching enzyme. And this debranching enzyme is involved in both liver glycogenolysis and muscle glycogenolysis. Yes, Armugarajesh. So type 3 Hurst, it's involved in both liver and muscle glycogenolysis. When liver glycogenolysis is defective, what will it present us? Liver glycogenolysis defect will present us hypoglycemia. When muscle glycogenolysis is defective, what will it present us? Exercise intolerance. Yeah, it will present us exercise intolerance. So if I ask you, how will you differentiate type 1 or von Gierke's and type 3 or Hurst? Both present with hypoglycemia, but type 3 can be differentiated. Reason is in type 3 there is also exercise intolerance and CKMM level will be elevated. Okay. Now look at type 6. Hurst disease caused by a defect of liver phosphorylase. So which pathway is defective? Liver glycogenolysis is defective and that is going to present as what? Liver glycogenolysis is defective. What is it going to present us? It is going to present us hypoglycemia. So how will you differentiate type 1 and type 6? You told me you will differentiate type 1 and type 3 because type 3 presents with additionally exercise intolerance. Now both type 1 and type 6 present as hypoglycemia. So how will you differentiate the two conditions? As I told you, which will not respond to counter-regulatory hormone administration? Yeah, which will not respond to counter-regulatory hormone administration. Von Gierke's will not respond to counter-regulatory hormone administration. Whereas what happens if it is Hurst? In Hurst, it's a defect of only liver glycogenolysis. So what is normal? Gluconeogenesis is normal. So in this case, if you start a counter-regulatory hormone, what do you expect? Gluconeogenesis will be stimulated and blood glucose will be increased. So type 6 will respond to counter-regulatory hormone administration whereas type 1 will not. Okay. So now do you understand why I wanted you to concentrate on 1, 3 and 6 alone? Among glycogen storage disorders, among glycogen storage disorders, what are the disorders which will present as hypoglycemia? Please remember hypoglycemic conditions. Memorize it. It is type 1, type 3 and type 6. Okay, type 1, type 3 and type 6. So type 3 will have exercise intolerance. 1 and 6 can be differentiated by administering counter-regulatory hormone. Clear? Okay, now I want you to look at type 5 and type 7. Check type 5 and type 7. Type 5 is Madras disease caused by a defect of muscle phosphorylase. When muscle glycogenolysis is defective, it will not affect blood glucose, but it is going to cause exercise intolerance. So what will you find here? You will find here exercise intolerance particularly to anaerobic exercises. Now type 7, glycolytic enzyme defect, again will present as exercise intolerance. Along with that, what will you find? You will also find hemolytic anemia. Yeah, along with that, what will you find? You will also find hemolytic anemia. So tell me, among glycogen storage disorders, what are the conditions which will present as exercise intolerance? All of you? There are two conditions. Actually, there are three conditions which present with exercise intolerance. What are the three conditions? As I told you, type 3, type 5 and type 7. Type 3, type 5 and type 7. Type 3 or Hurst will present along with hypoglycemia. Type 3 will present along with hypoglycemia. Type 5, very good all of you. Yes, excellent. Srishti, Aditya, Muthu, Vijay, Shankar, good. So type 3 will present along with hypoglycemia. Type 5 will be purely exercise intolerance. And in type 5 there is something called a second wind phenomenon. Yeah, in type 5 there is something called a second wind phenomenon, about which I'll tell you in the next class. For now just memorize type 5 is characterized by second wind phenomenon. Type 7 there is exercise intolerance, but along with exercise intolerance there will also be hemolytic anemia. Clear? So exercise intolerance type 3, type 5 and type 7. Okay. So what are we left with? We are left with type 2 and type 4. Yeah, we are left with type 2 and type 4. Okay. So about type 2 Pompey's disease, as I told you, it's a defect of a lysosomal enzyme which is alpha glucosidase. And here I want you to know that 2% of the glycogen that is stored in liver and muscle, yeah, 2% of glycogen which is stored in liver and muscle will be metabolized by lysosomal enzyme. So when that enzyme is defective, that 2% of glycogen will accumulate in these places. So when they accumulate in liver, what will it cause? It will cause hepatomegaly. Yeah, it will cause hepatomegaly. Then it accumulates in cardiac muscle fibers. It will present as cardiomyopathy. Cardiomegaly and cardiomyopathy. It is not going to present as hypoglycemia. It is not going to present as exercise intolerance. Do you all understand this? Pompey's, it is a lysosomal enzyme defect. It is not related to maintaining blood glucose. It's not related to person exercising. So it is not going to present as hypoglycemia or as exercise intolerance. Instead, what will it present as? It will present as hepatomegaly, cardiomegaly, cardiomyopathy. Okay, so that's about type 2. How about type 4 or Anderson's disease? It is caused by a defect of branching enzyme. Yeah, so branching enzyme helps in accommodating more number of glucose molecules in a limited space. That is its main purpose. Do you understand this? Branching enzyme main function is to accommodate more number of glucose molecules in a limited space. When that does not happen, again larger glycogen will be stored. Yeah, longer glycogen will be stored. So that also causes hepatomegaly first. Yeah, that also causes hepatomegaly first, then it causes liver cirrhosis. Yeah, then it causes liver cirrhosis. Yeah, so that's about Anderson's disease, which is caused by a defect of branching enzyme. Clear? So this is how you can group these glycogen storage disorders and you can memorize them. Okay, so I'm going to repeat it. I'm not going to repeat it entirely. How do we characterize or how do we categorize glycogen storage disorders? The first group of glycogen storage disorder would present as hypoglycemia. Those which present as exercise intolerance. Those which do not present with any of these. Okay. Now what are the hypoglycemic glycogen storage disorders? It is type 1. Type 3 and type 6. Yeah, 1, 3 and 6 present with hypoglycemia. Of the three, the most severe form of hypoglycemia which does not respond to counter-regulatory hormone administration will be type 1 or von Gierke's disease caused by a defect of glucose 6-phosphatase. Type 3 or Cory's disease, debranching enzyme defect will present along with exercise intolerance. Okay. Type 6 is Hurst disease. It presents as hypoglycemia which responds to counter-regulatory hormone administration. Okay. Now what are the disorders which present as exercise intolerance? 3, 5 and 7. Yeah, exercise intolerance will be 3, 5 and 7. And 3, you know, it presents along with hypoglycemia. 5 or McArdle's will present as exercise intolerance and there is second wind phenomenon. Yeah, McArdle's or myophosphorylase defect will present with second wind phenomenon. Type 7, it is a glycolytic enzyme defect. The moment you hear the word glycolytic defect, immediately RBC should come into your mind. When RBCs get affected, it will present as hemolytic anemia and as exercise intolerance. Clear? I hope it's clear to everybody. Yeah. So apart from this, yeah, this is the summary which I told you just now. 1, 3 and 6 present with hypoglycemia and how to differentiate 1, 3 and 6. Okay. So apart from this, I want you to know few facts about von Gierke's disease. Okay, few more facts about von Gierke's disease because this has been frequently asked. So it is caused by a defect of what? Glucose 6 phosphatase. When glucose 6 phosphatase is defective, glucose 6 phosphate cannot be converted to glucose, right? So the excess glucose 6 phosphate gets into glycolysis. And what will you get as a result of glycolysis? You get pyruvate. Yeah, you get pyruvate. And the excess pyruvate initially will get into acetyl-CoA formation. And these acetyl-CoA molecules, just now in the special session I told you, acetyl-CoA will be used for fatty acid synthesis and cholesterol synthesis. The excess fatty acid will be stored as triacyl glycerol. Excess cholesterol will be stored as cholesterol ester. Okay, so apart from hypoglycemia, one biochemical feature of von Gierke's disease is hypoglycemia. Along with that, what are you going to observe? You will observe hypertriglyceridemia and hypercholesterolemia. Okay, not always acetyl-CoA can get into all these anabolic pathways. So at one point, acetyl-CoA accumulates. And whenever acetyl-CoA accumulates, it condenses to form ketone bodies. Yeah, so what you will find is ketosis. So not only hypertriglyceridemia and hypercholesterolemia, you also observe ketosis. Now this acetyl-CoA in a feedback mechanism inhibits PDH complex. So pyruvate accumulates. And this pyruvate gets converted to lactate. Yes, Safin, you're right. Excellent. So pyruvate gets converted to lactate. So what you would observe is additionally lactic acidosis. And this lactic acid inhibits glycolysis. So glucose 6 phosphate is in a fix. Neither can it be converted to glucose nor can it get into glycolysis. So excess glucose 6 phosphate gets into HMP shunt. Yeah, excess glucose 6 phosphate gets into HMP shunt. Can any one of you, very good Bilal, so can any one of you tell me what happens when excess glucose 6 phosphate gets into HMP shunt? It forms ribose 5-phosphate. That is why HMP shunt is otherwise called as pentose phosphate pathway. Pentose phosphate because it acts as a source of ribose 5-phosphate. Ribose 5-phosphate will be used for purine and pyrimidine nucleotide synthesis. Excess purine will be catabolized to form uric acid. So what you find is hyperuricemia. Okay, so these are the biochemical features of von Gierke's disease. So I am going to repeat this. In von Gierke's disease, the enzyme that is defective is glucose 6 phosphatase. Very good, Armuga Rajesh. So it is the enzyme that is defective is glucose 6 phosphatase. When glucose 6 phosphatase is defective, blood glucose decreases. So obviously it presents as hypoglycemia. And additionally, what will you find? Excess glucose 6 phosphate gets into glycolysis, forms pyruvate. Pyruvate gets converted to acetyl-CoA. Acetyl-CoA is used for fatty acid and cholesterol synthesis. Excess fatty acid will be stored as triacyl glycerol. Excess cholesterol will be stored as cholesterol ester. So the child, the neonate, will present with hypoglycemia, hypertriglyceridemia, hypercholesterolemia. Acetyl-CoA accumulates, causes ketosis. Acetyl-CoA inhibits PDH complex. So pyruvate gets converted to lactate. So there is lactic acidosis. Lactic acid inhibits glycolysis. At one point, glucose 6 phosphate will not be able to enter into glycolysis also. So glucose 6 phosphate gets into HMP shunt. Through HMP shunt, what do you get? You should remember HMP shunt is otherwise called as pentose phosphate pathway because it acts as a source of pentose phosphate, which is ribose 5-phosphate. And ribose 5-phosphate is like a foundation based on which you build all nucleotides. So ribose 5-phosphate is used for purine and pyrimidine nucleotide synthesis. Excess purine will be catabolized to form uric acid. So you find hyperuricemia. So can you summarize what are the biochemical features of von Gierke's disease? It is hypoglycemia, hypertriglyceridemia, hypercholesterolemia, ketosis, lactic acidosis, and hyperuricemia. Okay, so that's all about von Gierke's disease. So what is the answer to this question? A neonate presents with hypoglycemia which does not respond to counter-regulatory hormone administration. What is your answer? Your answer is von Gierke's. Okay. So the next question, you're right, Ravneet Kaur. So the next question is a curiosity question. What will be the level of insulin or glucagon level in von Gierke's? Because there is hypoglycemia, insulin level will be low, glucagon level will be high. It is, I won't say it's incompatible with life. To some extent, yes. If you want the neonate to sustain life, all that you will have to do is you will have to keep the child on a continuous IV glucose drip or frequent small meals, depending upon how low the enzyme activity is. Yeah, if there is complete defect of the enzyme, yes, it's not incompatible. If there is partial defect of the enzyme, then there will be some time wherein the child will be able to maintain blood glucose based on dietary glucose. So frequent small meals and continuous IV dextrose are the two ways by which you can sustain life. Clear? Okay. Yeah, a person visits his physician following his visit to tropics with jaundice. Jai Shri Ram. Oh, what is that? With jaundice. Blood picture reveals hemolysis. His CK-MM level is normal. Okay. The probable enzyme defect is. What is your answer? Some of you have answered it as C. Who has answered it as C? Vikram has answered it as C. Narendra Singh has answered it as C. Sai Charan Good has answered it as D. Banu Prakash thinks it's A. Okay. So can we start from choice A? Yeah. So can we start from choice A? So summarizing this, it's a very small question, right? This is how FMGE questions are asked. Yeah, the stem is very small, but the concept is really good. Okay. So what are the findings here? There is hemolytic jaundice. Yeah, there is hemolytic jaundice, but CK-MM level is normal. Yeah, CK-MM level is normal. So some of you have answered it as choice A or phosphofructokinase 1 defect. So what is phosphofructokinase 1 defect, otherwise called as Taruv's disease? Yeah, it is otherwise called as Taruv's disease. And in Taruv's disease, if it's glycolytic enzyme defect, what did I tell you? Both RBCs and muscle will get affected, right? Both RBCs and muscle will get affected. When RBCs get affected, it will present as hemolytic anemia and hemolytic jaundice. But when muscle gets affected, CK-MM level will be elevated. Yeah, because CK-MM level here is normal, I am going to exclude all glycolytic enzyme defects. Yeah, I am going to exclude all glycolytic enzyme defects, namely choice A and choice B. Is it clear to everybody? Yeah. Now look at choice C. Some of you even answer it as choice C, and we can exclude choice C because, hi Rahul Sharma, because if you exclude choice, because if it's choice C or glucose 6-phosphatase defect, what do you think will be the presenting feature? Just now we discussed in detail about von Gierke's. It is going to present as hypoglycemia. Yeah, it is going to present as hypoglycemia. So definitely it's not choice C. So what are you left with? You are left with glucose 6-phosphate dehydrogenase defect. So what is that you all know about glucose 6-phosphate dehydrogenase defect? We know glucose 6-phosphate dehydrogenase is an enzyme of HMP shunt. Yes or no? Yeah, don't get confused between glucose 6-phosphatase and glucose 6-phosphate dehydrogenase. Though we think we won't get confused, many a times I've seen students getting confused here. So glucose 6-phosphatase defect is von Gierke's, it is hypoglycemia. Glucose 6-phosphate dehydrogenase is an enzyme of HMP shunt. And what are the two significances of HMP shunt? Yeah, HMP shunt has got two significances. One is that it acts as a source of NADPH. Yeah, it acts as a source of NADPH. The other significance is that it acts as a source of ribose 5-phosphate. And just in the previous question, I told you ribose 5-phosphate is necessary for purine and pyrimidine nucleotide synthesis. So this significance we already know. So what is the significance of NADPH? NADPH is necessary for reductive biosynthesis of all lipids. Yeah, be it fatty acid synthesis or cholesterol synthesis or bile acid synthesis or steroid hormone synthesis. So all these lipids, when they get synthesized, they'll involve multiple reduction steps. And for all those reduction steps, you need a hydrogen donor. What would act as the hydrogen donor? It is NADPH. Okay, so it is necessary for fat synthesis. And the other significance of NADPH is that it is necessary for regenerating glutathione. It is necessary for regenerating glutathione with the help of glutathione reductase. And glutathione is an important antioxidant mechanism of RBCs. Yeah, it is an important antioxidant mechanism of RBCs. So it helps in RBCs to regenerate glutathione. So tell me what happens in glucose 6-phosphate dehydrogenase defect, all of you. When glucose 6-phosphate dehydrogenase is defective, NADPH will not be synthesized. Without NADPH in RBCs, glutathione cannot be regenerated. So RBCs do not have an effective antioxidant mechanism. So following exposure to an oxidative stress, RBCs undergo lysis. So glucose 6-phosphate dehydrogenase defect will present as hemolytic anemia. Yeah, it will present as hemolytic anemia following exposure to oxidative stress. Yeah, following exposure to oxidative stress. Yeah, example for oxidative stress is exposure to prophylactic drug for malaria. Yeah, following intake of primaquine, there is an oxidative burst, and when there is an oxidative burst, there should be a rapid rate at which glutathione has to be regenerated, for which we want NADPH, but NADPH is not synthesized in a person wherein there is G6PD deficiency. Then they present with hemolytic anemia. So the clue that is given to you is a person visits his physician following his visit to tropics. So tropics are known for malaria. So the physician might have prescribed him oral prophylactic drug for malaria, which is primaquine. And that would have initiated the hemolysis. Then he has presented with hemolytic jaundice. So for workup, of a case with hemolysis, and if you suspect an inborn error of metabolism, the most common cause of inborn error of metabolism presenting as hemolysis would be G6PD deficiency, and that is followed by glycolytic enzyme defects. And among glycolytic enzyme defects, which is more common? Pyruvate kinase defect is more common, and phosphofructokinase 1 defect is relatively rare. Okay, so if a person presents with hemolytic anemia or hemolytic jaundice, and if you suspect an inborn error of metabolism as a cause of hemolysis, which is the most common cause? G6PD deficiency, followed by pyruvate kinase defect, followed by phosphofructokinase 1 defect. Now to differentiate these two categories, what is that you need to estimate? You estimate CKMM level. If CKMM level is elevated, then it is glycolytic enzyme defect. If CKMM level is normal, and if history clearly tells you that there is hemolysis only following exposure to an oxidative stress, then that is G6PD deficiency. Clear? So what is answer? The answer here is the probable enzyme defect is glucose 6-phosphate dehydrogenase defect. Okay. A child was developing normally until he was weaned from mother's milk with infant foods. He then presented with hypoglycemia, hypophosphatemia, lactic acidosis, and hyperuricemia. So what do you find? Hypoglycemia, hypophosphatemia, lactic acidosis, and hyperuricemia. The probable enzyme defect is, Narendra Singh says it's for sure it's B. Ahmed says it's D. Yeah, this is Narendra Singh's answer. Ahmed says it's D. Habib Bilal says it's D. What do you think is the right answer, all of you? Okay, again let's start excluding choices one by one. Let's not straight away jump into an answer. Let's try to exclude choices one by one. I'm going to exclude choice A. On what basis am I going to exclude choice A? Because if it's a galactose metabolism disorder, galactokinase, the name tells you it's galactose metabolism disorder. So if it's galactose metabolism disorder, all these manifestations would have presented even when the child was mother fed. Because you know, mother's milk, yeah, mother's milk has got lactose. And you know, lactose gets digested in the intestine to give galactose and glucose. And that galactose would have entered into circulation even then. So if it's a galactose metabolism disorder, all these manifestations should have appeared. Yes, should have appeared even when the child was mother fed. So based on just this history, I am excluding choice A and choice D. Yeah, I am excluding choice A and choice D because both are galactose metabolism disorders. I am left with choice B and C. I am going to exclude choice C as well because I want you to know whenever it is fructokinase defect, yeah, whenever it is fructokinase defect, we call that condition as essential fructose urea. What do we call that condition as? Please memorize it. Fructokinase defect is called as essential fructose urea. And in essential fructose urea, as the name indicates, essential means no pathological defect, no metabolic defect. You cannot expect hypoglycemia or hypophosphatemia or lactic acidosis or hyperuricemia. The only finding is fructose is found in urine. It will be an accidental finding. Suppose the person gives his or her urine for checking for the presence of reducing sugar. Accidentally it turns out to be positive. Okay. So that's about essential fructose urea, which is not, which does not present with any metabolic derangement. So that is why I am excluding choice C. So what are we left with? Yes, does not cause any symptoms. So what are we left with? We are left with only choice B, which is aldolase B defect. And aldolase B defect is called as hereditary fructose intolerance. Yeah, aldolase B defect is called as hereditary fructose intolerance. So let's now try to understand does she appear so strict to you? Oh, no. No, I have not pulled ears of any student so far. Okay, so aldolase B defect, hereditary fructose intolerance. What was I telling you? Yeah, before we discuss about all these inborn errors of metabolism, I will tell you about normal fructose metabolism. Yeah, listen to this. So as soon as fructose gets into any cell, yeah, whenever a hexose gets into any cell, the first step's aim would be to trap the hexose within the cell. Similarly, as soon as fructose gets into any cell, we have to trap fructose within the cell, for which the enzyme which we use is fructokinase. So what is the first enzyme which begins the metabolism of fructose? It's fructokinase, which converts fructose into fructose 1-phosphate. Now this fructose 1-phosphate is immediately cleaved by the next enzyme. And the next enzyme is aldolase B. The next enzyme is aldolase B. So do you remember aldolase A is involved in glucose glycolysis, aldolase B is involved in fructose glycolysis. So what is the difference between glucose glycolysis and fructose glycolysis? In glucose glycolysis, first hexokinase or glucokinase converts glucose into glucose 6-phosphate. Then phosphofructokinase 1 converts fructose 6-phosphate to fructose 1,6-bisphosphate. In glucose glycolysis, it is fructose 1,6-bisphosphate that is being cleaved by aldolase A. And that is why when you get two trioses, both the trioses will have one phosphate attached each. So what are the two trioses we get? We get glyceraldehyde 3-phosphate and dihydroxyacetone phosphate. Yeah, in contrast to that, In fructose glycolysis, it's only one kinase which converts fructose into fructose 1-phosphate. Yes, Shankar, you're right. Tricky question? It's not tricky. Once you have understood the concept, you will find it to be a simple one. Okay. So, in contrast to glucose glycolysis and fructose glycolysis, aldolase B cleaves fructose 1-phosphate to form 2 trioses. So, out of the 2 trioses, only one will have phosphate attached, and that is dihydroxyacetone phosphate. The other one is not glyceraldehyde 3-phosphate, it is just glyceraldehyde. Okay. So, aldolase B cleaves fructose 1-phosphate to form 2 trioses. One is just glyceraldehyde, the other one is dihydroxyacetone phosphate. Now a triokinase converts glyceraldehyde into glyceraldehyde 3-phosphate. Now that we have both the intermediates of glycolysis, they'll now go through usual glycolytic steps. In the sense, every fructose on glycolysis will give rise to 2-pyruvate. Yeah, every fructose when it goes through glycolysis will give rise to 2-pyruvate. Are you clear about normal fructose metabolism? You understood normal fructose metabolism, right? What is the first enzyme? Fructokinase. No problem, Habib. I understood it's DHAP. So the first enzyme is fructokinase converts fructose into fructose 1-phosphate. Immediately it is cleaved by aldolase B to form 2 trioses. One is glyceraldehyde, the other one is dihydroxyacetone phosphate. Then triokinase converts glyceraldehyde into glyceraldehyde 3-phosphate. Now that you have got usual glycolytic steps, they go through usual glycolysis giving you 2-pyruvate. So fructose glycolysis, as Shankar Shiva mentioned. Yeah, Shankar Shiva mentioned. So fructose glycolysis skips the rate limiting enzyme of glycolysis. What is the rate limiting enzyme of glycolysis? It is phosphofructokinase 1. So that step is bypassed. Okay. Now tell me what happens when there is enzyme defects. Okay, I am going to tell you what happens when fructokinase is defective. When fructokinase is defective, as and when fructose gets into any cell. Yeah, as and when fructose gets into any cell, it cannot be trapped inside any cell. It comes out of the cell. It gets into circulation. So in this condition, fructose level in the blood is high. And this gets reflected in urine. So in urine, fructose level is high. Otherwise, because fructose is not getting trapped inside any of the cells, it is not going to cause any metabolic derangement. Only when something gets trapped within the cell, it will affect internally metabolism. It will cause hypoglycemia, hyperuricemia or anything of that sort. In this case, fructose is not trapped inside any cell. It harmlessly gets into circulation. It's harmlessly found in urine. That is why this condition is called as fructokinase defect is called as essential fructose urea. It is called as essential fructose urea. Now what happens when aldolase, yes Dinesh, you are right. What happens when aldolase B is defective? When aldolase B is defective, fructose is getting trapped in the form of fructose 1-phosphate within the cell. Yeah, when fructose 1-phosphate is trapped, you are not worried about fructose getting trapped. You are rather worried about phosphate getting trapped. Yeah, otherwise phosphate would have come out. Here it is trapped as fructose 1-phosphate. Because phosphate is getting trapped, there will be low phosphate level in the person. Yeah, there will be low phosphate level. And when there is low phosphate, glycogenolysis will be impaired. Because glycogenolysis is done by glycogen phosphorylase. When there is low phosphate, glycogenolysis is impaired. When glycogenolysis is impaired, it causes low glucose. That is why there is hypoglycemia in hereditary fructose intolerance. So in hereditary fructose intolerance, low phosphate causes low glucose. When there is low phosphate, ADP cannot be converted to ATP. Yeah, when there is low phosphate, ADP cannot be converted to ATP. So all cells concerned with fructose metabolism suffer from ATP deficiency. And fructose metabolism happens majorly in hepatocyte. When hepatocyte suffers from ATP deficiency, that causes jaundice. Yeah, that causes jaundice and hepatomegaly. When ADP is not converted to ATP, ADP has got no role to play. So unwanted ADP will be catabolized to form uric acid. Yeah, it will be catabolized to form uric acid. So this causes hyperuricemia. Okay, this causes hyperuricemia. And whenever there is hyperuricemia, uric acid prefers to get secreted along the renal tubules. So what will accumulate? Lactic acid accumulates. Do you understand this? In distal convoluted tubule, there is one H plus transporter which secretes all hydrogen ions. So when there is hyperuricemia, predominantly uric acid H plus will get secreted. So lactic acid accumulates. And that causes lactic acidosis. Yeah, that causes lactic acidosis. And classically all these features will be observed only after a person takes fructose. That is why it is called as hereditary fructose intolerance. Do you understand this? That's why this condition is called as hereditary fructose intolerance. Are you all clear about this? Yeah. So what are the two defects I've told you in fructose metabolism? In fructose metabolism, there are two defects. One is fructokinase defect is called as essential fructoseuria. Then you don't find any metabolic derangement. There is only fructose which is found in urine. And the second condition that I've told you is, when aldolase B is defective, we call it as hereditary fructose intolerance. And in hereditary fructose intolerance, what do you observe? In all cells, fructose is trapped in the form of fructose 1-phosphate. You're not worried about fructose getting trapped. You're rather worried about phosphate getting trapped. So phosphate level is low. Yeah, when phosphate level is low, glycogen phosphorylase, as the name indicates, this enzyme needs phosphate. So without phosphate, glycogen phosphorylase becomes inactive. Glycogenolysis is inactive and that causes hypoglycemia. So low phosphate, low glucose. When there is low phosphate, ADP cannot be converted to ATP. So all cells concerned with fructose metabolism suffer from ATP deficiency. Fructose metabolism happens in liver. When liver gets affected, that presents as jaundice and hepatomegaly. When ADP is not converted to ATP, unwanted ADP will be catabolized to form uric acid. That explains hyperuricemia. Hyperuricemia precipitates lactic acidosis. Okay, so that's all about all these conditions. So, do you understand that everything has been explained here? A child was developing normally until he was weaned with infant foods. And any infant food, any formula food is known for its high sucrose content. Yeah, sucrose gets digested. Source of lactic acid is normal metabolism generates lactic acid, Dinesh Kumar. And normally this lactic acid gets secreted in the distal convoluted tubule. And the same DCT is responsible for secreting uric acid also. In this condition, there is hyperuricemia. So uric acid H plus will prefer to get secreted, causing lactic acid to accumulate. Do you understand this? Okay. So any infant food or formula food is rich in sucrose, and sucrose gets digested to give equimolar glucose and fructose. Okay, this fructose has entered into the person's system and then it has caused all these features. So hypoglycemia is because low phosphate inhibits glycogenolysis. Hypophosphatemia because fructose is trapped in the form of fructose 1-phosphate. Lactic acidosis because uric acid does not allow lactic acid to get secreted. Hyperuricemia because ADP is catabolized to form uric acid. So all these will explain one condition, which is aldolase B defect. And what is that called as? It is called as hereditary fructose intolerance. Okay, clear? So these are the MCQs which I wanted to discuss with you. I'll be continuing this with another session of case-based MCQ, and again all clinical case-based MCQs will be based on inborn errors of metabolism. At some point I'll also discuss about function tests. Okay, thank you, good night.